And the guy that I watched the video from is a cardiologist.
Uh-huh. So it's reliable. It's not like just some guy that, yeah. Computer is so slow, you guys. Yes, everything. I completely agree, including me, including everything. I agree. I agree. Okay. Okay, if you guys haven't been watching the weather or anything like that, we are basically at increased risk for severe weather, but pretty much most of this week. And definitely today, definitely later on today, more than like right now. But yeah, afternoon will be the bigger risk. Highly recommend, even if you didn't today, highly recommend for the rest of the semester. I'm not kidding when I say the rest of the semester. Park in the parking garage if you can. I'm not kidding, because hail and, you know, strong winds and that sort of stuff, if you care about your car, park it, right. If you don't care and you're ready for that insurance money, man, just do you. So I don't know for sure. I think that the first level is faculty and staff, but I think that upper levels are for everybody, is my understanding. Everywhere. Yeah. So technically, if you guys didn't know this, technically to park in our parking lot, you're supposed to have a parking permit. And so anybody that doesn't have a parking permit can get ticketed. No. Yeah, yes. Okay. So, right. So nobody tells you. Nobody tells you. Right. So they don't care about it too much. They don't care about it. Yeah, so it's for for parking on campus in general. You're supposed to have a parking permit. They don't care about it too much if you're not parking in faculty or staff parking. So if you're parking in the regular parking, they're usually not going to check it. But it might become an issue if you were driving recklessly and you parked and like hit somebody's car and you also didn't have a permit, they could also ding you for not having a permit. So just so you know, yeah, and it costs money. Don't get me started on how stupid I think that is. Because faculty also have to have faculty and staff permits. And so we have to make sure that, like, if I borrow my husband's car, if I don't take my permit out of my car because it's in the shop or something, and I park in faculty or staff, then I can get dinged for parking in faculty or staff parking. Yeah. Yeah, Stillwater was like that. If you guys don't know too, if you were to have gone to Stillwater instead of here, every single person, it doesn't matter if you're parking in this parking lot or that parking lot. Every parking lot has a specific permit, and whatever color permit you have, you can only park in that parking. If you park anywhere outside of that, you can get like $300 tickets just for parking outside of that. And if you guys ever go to Stillwater to go like a football game or something like that, you can get dinged for parking in like those colored parking areas. So we're talking about walking like over a mile just to get to the campus. It's anyways, because I lived on Stillwater campus. It was a nightmare. What was you? We are. I was just pulling this up so that I had it. Yes, we're going to do a Kahoot. So we have already done the Kahoots for chapter 16. So you guys, we're going to do 2 questions from chapter 16 we've already done it. just to get our attendance. So I'm gonna pull it up and we're gonna give some leeway to let people finish trickling in. We're gonna answer 2 questions from that Kahoot just for attendance purposes. Okay, if I sent out the announcement to you guys yesterday saying like, hey, by the way, on Saturday, I gave a review, and on Saturday's review, I went over the immune response. I didn't go over any of the slides for the review. So like normally I'll go over like the most missed topics and I could go over example questions for that. That stuff is in the slides and you guys are welcome to review that stuff from the slides, but I highly recommend you watch the video that is posted. And I also put the link to that video in that announcement. It's the same video. If you want to see the whiteboard that I drew along with it, the whiteboard is available in the discussion area. That's also, discussion is also linked in that announcement. But if you're confused about how, you know, T helper cells are activated versus the CD8 cells and what MHC2 versus MHC1 is doing in those things and how the B cells get tied in with all of that stuff, that's still blurry for you. Watch that review because I go over those things. Now that we know what a lymphocyte is and what a T cell is, now that review puts into perspective from the beginning of seeing the antigen and having your innate response all the way into your acquired responses and how they're governed. So if you need help with understanding that stuff, please watch that video. And if that still is a little bit blurry for you, you can always come see me in my office hours or email me for clarification on that stuff so you can make sure you're understanding it before moving forward. All right. Anybody have any questions about anything in particular before we get started with everything? Having an understanding of the antibodies, like what antibodies do for our body, as well as the T cell stuff is going to help you a lot today because we're going to blow through chapters 17 and 18 today. And we're going to get both of them in, but it's going to mean, you know, just another one of those kind of whirlwind days there. I'm not going to lie. Library. Yes, question. Okay, so our lab, like our media that, remember how we only inoculated blood auger last time? So our autoclave is working now, but we're going to do simulations for staph media, for mannitol media, for EMB, and for McConkey. I have pictures for those that we're just going to refer to our results from those pictures. But moving forward, everything has media. And so we'll have media for everything else. For lab 13 that we're inoculating today, moving forward, they all have media for those. So this will be a simulation for lab 12 results, but everything forward will have media for. Yeah, man, it's one of those days for me too. We are looking for chapter 16. If I don't say it, I'm going to forget what I'm doing. 16. Thank you. Okay, so we'll do live. We'll do the login. I'm going to give a couple more minutes for potentially people to trickle in. We absolutely will not be going over the class questions at the end of the chapter. And I'm probably not even going to go over them because I want to save as much time as I can to actually cover 17 and 18. But if you look through those questions, and I would recommend looking through them and making sure they make sense to you. And if you don't know what the answer is, or you're not sure, like if you're getting it, always can email me for clarification, okay? Also, the Kahoots, since we're not doing the Kahoots for chapter 17 or 18, they are on Canvas and you are welcome to do them in your own time. The ones that are on Canvas are the same ones that we do in class. Okay. Let's get some sound on this thing. everybody sign in.
So the reason it wouldn't let me redo the new is because I was trying to do it on my phone and it wouldn't let me redo a thing.
Okay, did it let you do it on a computer though, at least? Okay. I don't
Something
know.
wouldn't
I don't know why the phone doesn't like have the same options. Yeah.
Well, sometimes sometimes it doesn't mean I'll like change my name or like
Yeah.
add an extra S at the end.
Yeah.
It wouldn't even let me do that.
Yeah. Sometimes it like watches your account.
Yeah.
Also, if you've done it, you can go to study and there's different ways to do it.
Yes, and so that's a little more complicated to show people how to use, but there is a way, like after you've done it, there's like you can turn it into flashcards and things like that through the Kahoot account. If you access it through the computer, you can get to those functions a little bit easier. And so it can actually let you study it, or it will let you create flashcards from it and things like that for on the computer side of that. Let me go on that Kahoot. She's talking about, just to be clear, she's talking about the Unit 3 review Kahoot. So we will have a game for Unit 3 on Sunday, like we kind of did in the past for Units 1 and 2. For Unit 3, we'll have a game on Sunday, probably at like, I don't know what time, 5 or something like that. And we'll again just do about an hour, unless there's interest to stay longer. We might stay maybe half an hour longer, but you know I have life outside of that too. So maybe an hour to an hour and a half of games on that Unit 3 Kahoot. And so you can like have the timer, have the pressure of competitiveness and everything like that with reviewing those questions. That we will do that on Sunday for those of you who want to do that. I'll send out an announcement about that probably on Wednesday. Keep weather aware. I did just send out an announcement saying that if class cancels for weather, they'll send out the blast emails like we do for the ice days. They'll say, you know, the campus will be closed at 4 p.m. for severe weather or something like that. If this happens to any of our classes in the future, whether that is Thursday, for example, there might be severe weather on Thursday. Our class might get canceled on Thursday. It's clearly not going to get canceled today or we would have heard about it. But if it happens on Thursday, look on that announcement and you'll know what to expect for that day. Okay. So I said for Thursday, if we miss lecture because of severe weather on Thursday, then you will not present your presentations and I will grade you based on what is submitted on there. There's just not enough time for me to move things to allow for that. Okay, so if Thursday gets canceled, I'm just going to grade you on what has been submitted on campus. There will be some grace there. Yes.
So our exam is Tuesday.
Is Tuesday, yes. The exam is Tuesday. So we don't have next week's like what if on there, right? If there is severe weather on Tuesday and they cancel class for Tuesday at 10 a.m., then we'll have to move the exam to Thursday, okay? And if we move it to Thursday, that means that the lecture that would have been given on Thursday for Unit 4 will have to be combined on another day. So we can't like cancel a chapter, we can't just cut it out, we'll have to squeeze it in. I hate squeezing it in, I already feel like we squeeze things in, and so I don't want to have to do that, but the other option is we'll either do it on another day or I'll just say, hey, watch the recording for this chapter, which I'd rather do in-person discussion if we can, just because I feel like we get more from in-person stuff than watching a video. I mean, if you guys are anything like me, when I watch recordings of things, I'm also distracted by life around me. But if you're in the class, like, you know, you're more likely to focus on what's going on in the class. So, which is why you guys show up, honestly. So, okay. I think we're good. Everybody ready to start with the Kahoot? We're just going to let's do 3 questions. Just to remind us of that content, and then we will jump into chapter 17 and 18. All right, first questions, and you've seen these questions before. Where do all lymphocytes begin development? They all start in the same place. Whether you are a B cell or a T cell, lymphocytes, our B cells and T cells, start out in the same place. All right, so that's the bone marrow. Great job. A lot of us are getting this one. So they start out in the bone marrow. The T cells finish their maturation and development in the thymus, but the B cells completely do everything in the bone marrow, but they all start out in the bone marrow. And that is from that hematopoietic stem cell precursor cell. Next question. During maturation, lymphocytes weed out anti-self clones and then will only proliferate the clones for that specific antigen that you're seeing. There's a term for this. What was that term for that whole process? Getting rid of the anti-self guys and only populating out the ones against that specific antigen. It's a process called. Right, so this is called clonal selection. So for these other things, clonal awareness and clonal culling, these are not terms that are associated with what we're learning. Selective toxicity is a term from chapter 12, and that was relating to our antimicrobial drugs. Just to remind us, because it will be on the test, right? Selective toxicity is the idea that you want drugs to be toxic to the pathogen and non-toxic to the host. That's the selective toxicity. You want it to be that. That's the idea of that. If you're looking at the exact ratios of where it's toxic to the bad guy and toxic to the host, if you're looking at the ratios between those, that is called therapeutic index. And the difference of the range between those two is the therapeutic window. Just to go back to chapter 12, because it's coming, y'all. We got a week. We got a week till that exam comes. Okay. What is the term for something that is too small to elicit a proper antibody response? It's cute. All right, so this is hapten. And so that's just a term that we'll need to know. A toxin is anything that would cause damage to the host, that would either trigger the inflammatory response or it itself is actually causing damage to the host. These are produced by the pathogens. And then we have toxoid, which is a type of a toxin. And that is basically just dealing with these small single unit toxins that can have effect. And you're not going to get tested over the term toxoid versus toxin, just FYI. We will do one more just to accommodate getting everybody counted down. Attendance. All right, choose all that apply. On which of the following cells do we see MHC2 markers? These cells are able to present antigens on MHC2. Remember that MHC, these are basically handles that present any antigen that is found, either if it's inside or if it's found from outside. If it is found from outside, it'll get presented on MHC2. And MHC2 only presents antigens from outside, and only antigen presenting cells can do this. So APCs are the only cells that can present outside antigen on MHC2. So you might be sitting here thinking like, well, it also says B cells. Yeah, B cells are antigen presenting cells also. So this is just kind of that opportunity to clarify that. So T cells are not the correct answer here. T cells do not present on MHC2. They, with their T cell receptor, recognize the antigen being presented by MHC2. So if I am a macrophage and I'm going out there and cleaning up all the mess that neutrophils left behind by eating up bad guys, I clean up that mess and I say, I found this crap from outside. This is something you can actually see. I found red cap marker from outside. They're just gonna hold up what they found from outside on MHC2. That's what the macrophages are gonna do. Then the T cell comes in with its T cell receptor and says, my receptor recognizes specifically red cap marker. Then because it's being presented on outside, the T cell CD4 recognizes the MHC2 molecule and says, yep, Lauren's cell is presenting something from outside. CD4 verifies that. The T cell receptor verifies that it is the antigen I'm supposed to react to. That activates your captain. So that's the T helper cell. That's your CD4 positive T helper cells. Only CD4 positive T helper cells see MHC2. only CD8 positive cytotoxic cells will see MHC1. There's no crossover there. So MHC1 presenting help, help, I found something inside of the cell. Any cell can call for help like that. So all cells can have MHC1 and call for help from stuff from inside. So they're sitting there saying, help, help, I found this inside of me. I don't know what it is. Then the cytotoxic T cell receptor says, hey, I recognize red cap marker. My CD8 recognizes that it's MHC1 presenting from inside. And then it recognizes that it's Lauren's cell saying something inside. Then that cytotoxic T cell will get a signal from a T helper 1 cell. That T helper cell, we already said, is a CD4 positive cell. It had to get activated by what kind of antigen? Outside antigen. No matter what, if you are a T helper cell, you got activated by outside. Always. Always. And that means it was presented on MHC2. And so MHC2 presents the outside, it activates T helper. T helper gets activated, it turns into TH1 and TH2. Those TH1 cells help activate the inside response. The TH2 cells activate the outside response. The inside response, that's your CD8 cytotoxic T cells. When they go recognize antigen on MHC1 with their CD8 molecule, and that's all happening, then the T helper cells give the go ahead. You can now make granzymes and perforins. Okay? On the outside side, those T helper cells are signaling the B cells that when you have recognized your antigen, and I've confirmed that's the correct antigen we're fighting, that captain, the TH2 captain, says that the outside response for the B cells can start. The B cells will then proliferate and differentiate into memory, regulator, and effector. The effector B cells are called plasma cells. They first make IgM, and then IgM will class switch into IgG, IgA, or IgE. Remember, there's also IgD, but that's just the receptor version on the surface that originally recognized the antigen and made the B cell be like, maybe I need to start getting to work. Okay, so that's the summary. And if you want more information and with drawings, the video that I posted on the announcements has this explanation as well as drawings that go along with it and shows who's activating who and everything like that. So if you want to look at that, that is available on the announcements. Okay, so moving on, we'll do one more question. And we're going to be done with this. Hopefully it applies to what I just said, kind of. What do cytotoxic T cells do? So the cytotoxic T cells are CD8 positive T cells. The CD8 is what recognizes that something's being presented on MHC1, saying that this is antigen from inside. If you're calling out saying, I found something inside of me, we're going to kill you. That's how we deal with this. So these cytotoxic T cells, they kill infected self cells by producing perforins that poke holes in the self cells and granzymes that break down everything in the self cells that go in through the perforated holes. And then that leads to the death of those cells. We call it like cell suicide. The word for that is apoptosis. All right, so that is it. We're going to show our little podium for what's gone on so far so you guys can see where you're at. You guys are doing great. And we're going to call it a day. Let's get into chapter 17. Now that we have a little review of our T cells. So we have two different types of T cells, the helper and the cytotoxic. And we've had a review of our B cells and the antibodies, right? So now we're going to get into chapter 17 and 18. All right. This is, of course, it's 18. All right, so chapter 17 deals with disorders in the immune system. This is pretty much going to be done with immunopathology. It's the fancy word for disorders of the immune system. Immunopathology is the study of disease states associated with either overreactivity or underreactivity of the immune response. When we're talking overreactivity, this also applies to reacting to things that you probably shouldn't be reacting to. You should only be reacting to pathogens when you're at risk for infection. But if you're reacting to things that aren't actually putting your health at risk, then that's an overreactive response. So having a reactive response from your immune system to identify cat dander as something foreign that you should attack, is that necessary or helpful to your body in any way? Are you actually preventing? No, it's not useful at all. So things like that is an overreaction response. We also have hyposensitivity or underreaction. The word for that is immunodeficiency. We are deficient in the amount of immune response we should have. So these are going to basically break up into two different versions. Let me see if I can, let's see if there's space on this next slide. This is kind of summarizing what we're going to get to. Hypersensitivity. Yes, and we'll talk about anaphylaxis today. So the first ones we're going to go over are our hypersensitivities. So this is our overreactions. There's 4 types: type 1, type 2, type 3, and type 4. Type 1 reactions are governed by immunoglobulin E, IgE. Type 2 reactions are governed by IgG and IgM antibodies. Type 3 is IgG complexes. What do I mean by complexes? A complex, let's write it down where there's a little more space, is whenever you have your immunoglobulin, your antibody, bound with an antigen. And these guys can kind of create large complexes with multiple antibodies interacting with multiple antigens. These complexes can get stuck in your very tight capillaries and your joints and tight spaces in the body. So while your body's trying to get rid of antigen, and it's proper antigen against a bad guy, it creates these antibodies that sometimes take a while for your body to clear out. Like your neutrophils will help digest that stuff. Your macrophages will help digest that stuff and get rid of it. But until it's gotten rid of, it can get stuck in your tight spaces in your body. And so when you have your immune globulin binding with antigen and it gets stuck in your capillaries or your joints, and your body is just triggering constant inflammatory response in those areas because it sees, hey, we've got antibody and antigen going on. That activates the complement pathway. Remember the classical pathway of complements? That can activate complement. It can also trigger your neutrophils to come in and try to eat things up, and other phagocytes to try to deal with opsonization and eating up things. And that causes damage to the nearby tissues, and that can lead to inflammation of those tissues. We'll talk more about what effects that can have in a little bit. That's led by this immunoglobulin plus antigen effect. We'll talk about how that differs from type 2 when we get to type 2. Type 4 is cell mediated. This is entirely your CD8 response. This is your T cell, your cytotoxic T cell. Okay, so types 1, 2, and 3, antibody. Type 4, your cytotoxic T cells. And it's killing your cells thinking that they are self-infected cells when that's not the case, when that goes awry. So those are our hypersensitivities. Our hyposensitivities that we'll get to in a minute, primary or secondary. Primary is genetically related. So these are genetic defects. Secondary is acquired. You guys know what AIDS stands for? Acquired immunodeficiency syndrome. And we've talked about this. We talked about this in the last chapter. If HIV infects your T helper cells that are your captains, and your captains govern all of your acquired immune response under that, if you're eliminating your captains, you're eliminating your immune response, and that causes immunodeficiency. It's acquired because you acquired it because you got an infection that caused this. You didn't have this from birth. It's not a genetic defect. You got it because you acquired it. So acquired immunodeficiency syndrome. It's a syndrome because it's got signs and symptoms that are associated with it being acquired immunodeficiency. That's a low T cell count, and then that susceptibility to opportunistic pathogens, as well as strange cancers that are normally kept under control by your immune system. So those are all signs and symptoms that are associated with that syndrome. Okay? All right, so we're gonna get into these. Let's do it. Hypersensitivity can be either triggered by something exogenous or endogenous. What I mean is You can either have overreaction to something coming from outside, like pet dander, pollen, peanuts, or drugs. Those are obvious ones that we're aware of that you can have overreactions to that isn't helping your body fight a pathogen. Or endogenous. This is usually associated with autoimmunities. You're attacking something that's inside and thinking it's foreign. That's usually going to be an autoimmunity attacking self. And again, type 1, 2, 3, and 4, and which antibodies mediate each of these. We're going to start with type 1. Remember, type 1 is going to be mediated by IgE. This is a type of antibody that's usually associated with attacking parasites. These are protozoa and our helminths. It's what it's designed for. All right. This leads to allergy. So allergy is having an inappropriate response to something that is not a pathogen, but isn't self either. So pet dander, pollen, and things like that. You usually have to have an initial sensitivity response, and then later on, you will be able to react instantly to it. And so once you have been stung by a bee once, you can get stung by the bee the first time and be fine. If you've only ever been stung by a bee once in your whole life, how would you ever know if you were allergic to bee venom? Because you wouldn't have had a reaction the first time. That would have been sensitizing. You would have been triggering, producing the IgE, but you wouldn't have had any response yet. Yes?
Is that why you have when like introducing allergens to babies, you have to do it like multiple times?
Yes,
before you can
exactly.
say it safe?
Exactly. So when you have babies, they'll recommend like, hey, if you're introducing something that's likely to cause an allergy, like peanuts, for example, you want to expose your baby a little bit for a few times because number one, your first time could be sensitizing or it could not be enough to sensitize. And so you're hoping that you've sensitized and you get a little bit the next time if they start showing any allergic reaction whatsoever. Now you know this baby is probably going to be allergic to this thing. The second time, or whatever it takes after you've had your sensitizing dose to activate IgE production against your allergen, the second time you see it is usually an instantaneous response. Within minutes, people have responses to those allergies. Let me tell you, anybody in here get itchy from a mosquito bite? Right. So pretty much everybody. You might think like, well, duh, the mosquito bite saliva makes you itchy. You have IgE in your body that attacks the mosquito bite saliva. That's what makes you itchy. So sort of like with the poison ivy, where we talked about not everybody's allergic to that. Poison ivy is a T cell response. That's our type 4, and we'll talk about it in a little bit. But it's just like that. So the oil from the poison ivy isn't causing you harm. Your immune system attacking the oil, thinking you're infected with something, is what causes the rash. Did you have a question? Okay. Okay. So allergens are anything that can trigger these types of reactions, whether it's type 1, 2, 3, or 4. An allergen is anything that is not a pathogen that triggers your immune response that is causing it to have a reaction where it's not actually beneficial for fighting a pathogen. Okay. And type 1 allergies, all led by, again, I will remind you, type 1 is always led by IgE. We have atopy and we have anaphylaxis. An atopic allergic reaction is like your mosquito bite. When you get bit by a mosquito and you have an allergic reaction to that bite, that's in a specific location in your body. It's local. So atopic is always local. It's chronic. Every time you see that thing, you're going to have an allergic reaction to it every time, whether it's mosquito bite or it is, hay fever, pollen, dander, dust mites, whatever you might be allergic to, peanuts, shellfish, that this is still considered a local allergy if it's atopic. So if you have a systemic allergy, like what we usually see with peanut and shellfish allergy, that this is anaphylaxis. If it's systemic, it's anaphylactic. If it's local, then it's atopic. So you guys ever heard of eczema? Eczema is an atopic dermatitis. So if you guys ever hear the term itis, this is a good time to bring this up. Itis means you're having inflammation. Always. So meningitis, inflammation of the meninges. Encephalitis, inflammation of the brain itself. When we talk about dermatitis, inflammation of the skin, right? Rhinitis, inflammation of the nose, sinusitis, inflammation of the sinuses, pharyngitis, inflammation of the pharynx or the throat. Starting to catch on a little bit, right? So anytime you hear itis, it always talks about having an actual inflammatory reaction in those areas. So atopic dermatitis. Atopic is local. Dermatitis is local to the skin and it's causing inflammation in the skin. Another term for atopic dermatitis is eczema. It's the same. They're interchangeable. So that's just the term that we've called it over history. And now we know that it's actually atopic dermatitis. And that's the more like specific term of what's going on there. And it is led by IgE. It could be caused. Usually eczema is not usually caused by contact, like you might think. Eczema is usually triggered by things that you ingest. So you're eating something and then it's causing you to have eczema. That's more common than other things, but it's still atopic. It's still an allergic reaction that we're seeing presented in the skin, not systemically. Okay. Anaphylaxis, when you have through your bloodstream acting throughout your entire body having an effect, and that's anaphylaxis. All right, the hygiene hypothesis states that if you are being exposed to these things that are sensitizing you and your body's getting trained to deal with IgE and using IgE for parasites, that your body now knows that IgE is dedicated to parasites. But if you're not exposed to those parasites, your IgE and your responses relating to your parasite response aren't getting trained to use that for parasites. And so we use it for allergies instead. And that's the hygiene hypothesis. The idea that the more that you're exposed to more things, the better your immune system gets trained on how to appropriately react. So we could see this as the more dirt you're exposed to, the more that you'll have a better trained immune system. All right. And so yes, the more dirt that you're exposed to, the less likely you're going to have allergies, but it's a lot more complicated than that, right? It's about training your immune system on what's appropriate to react to. Yes. That's where it's coming from. And so people didn't necessarily know that it's training your body, your immune system on what's appropriate and what's not. But that is, you have noticed, and you may have noticed this yourselves, people that grow up on farms and are outside more have less allergies than people that grow up in like a metropolitan area, because they're outside and they're exposed to more. Their body got trained on what's appropriate to react to and what's not. So if you grow up outside and exposed to outside things, this is actually why you're going to see coming up as we're seeing more people grow up that come from enclosed hygienic situations, that Gen Alpha and Gen Z are going to show more allergies than the millennials did and the boomers did. Yes.
So, I see target parasites.
Yeah,
So
typically.
Like kids that had scabies a lot as a kid. Is that a parasite? And would they less likely to have allergies?
Potentially, right? And so usually this comes along with, you're going to have a better training of your immune system, the more variety that you see. And so just having scabies might make you less likely to have allergies to dust mites, for example, or something like that. I can't make any guarantees about that, but that's the theory that could be related to that. And when we talk about parasites, we're not just talking about like those macro parasites like scabies or like mites or ticks or fleas or something like that. We're also talking about protozoa and helminths, so the microscopic parasites as well. So protozoa and helminths, the protozoa are always single-celled organisms. This is going to be malaria. This is going to be toxoplasmosis, trypanosoma, trichomonas, those guys. And if you're exposed to those earlier in life, that triggers your IgE response to dedicate itself to the parasite fighting function instead of, hey, I don't know what to do with IgE. Oh, what do I do with this? Because it never got trained on how to deal with it. Okay, so there's actual evidence that it shows that hygiene hypothesis, the more variety of antigens that you're exposed to, the less likely you are to have allergies. That's the hygiene hypothesis. It's training your immune system on how to react appropriately. Okay, our allergens, pretty straightforward. I'm not going to go over these really, but inhaling something, breathing it in, and then having an allergy to that, ingesting something, eating it, injecting something. This includes bee venom, as well as like vaccines or drug injections and things like that. And then contactants means that you're actually contacting with your surfaces onto other surfaces. Okay. So what happens in your type 1 response? This is just type 1, which again is relating to IgE. What happens is you see your antigen, your B cell is signaled to make IgE against the antigen. The whole reason that it's getting signals to make IgE instead of other antibodies or instead of not reacting to it at all is because we didn't get properly trained on when we should be making IgE. So we're making IgE to your antigen. Then the IgE is basically worn by our mast cells as receptors on the surface of the mast cells. So basically IgE is just antibody that's floating around in your body. The mast cells find the IgE and they grab onto those constant regions and they just hold out like little flags basically. So mast cells have special flag holders to hold on to IgE specifically. That constant region that makes IgE instead of IgG or IgM or something like that. The constant region that makes IgE, that allows mast cells to hold on to it. And it basically just waits until antigen is recognized by the IgE that it's holding on to. So that's what's going to happen next. Mast cells with IgE will get triggered by that antigen. And then they degranulate. And this is going to be, I can't spell right now, histamine, bradykinin, all of these things that are going to be associated with allergic reactions. This signals our inflammatory response. Okay, so that's the whole process of what's going on. You first see your antigen, your allergen in this case, what you're allergic to. You'll see your allergen. You'll activate your B cells to make IgE specifically against that allergen. The mast cells will wear the IgE around and just wait until the next time that you see the allergen. When they see the allergen the next time, they'll degranulate and release all this histamine. And that leads to the inflammatory response that we see with type 1 allergies. Okay? So what happens after that? This is just explaining what we just saw. Will lead to your either atopic or your systemic anaphylactic reactions. So if it's atopic, if it's just in these specific areas, hay fever leads to what we call allergic rhinitis or atopic rhinitis. Again, inflammation in the nose cavity. This can be triggered by pollen, mold, or anything that you could inhale into your nose area. Asthma, you're having an atopic reaction, not just in the nose, but now in your actual respiratory system, your proper lower respiratory tract. And so now you're triggering that inflammatory response and degranulation of the mast cells in your respiratory tract down lower. So that's asthma. It's still an atopic allergy response. Eczema is atopic allergy presented on the skin, usually through ingesting something or inhaling something, but that we're having degranulation and inflammation associated with mast cells in the skin reacting to those things that you got through other means. We also have food allergies. Food allergies can be having atopic symptoms or anaphylactic symptoms. So we know if you're allergic to peanuts, people with peanut allergies can inhale the particles of the peanuts, or they could ingest the peanuts, or they could come into contact with the peanuts. It doesn't matter, but if there's peanut particulate somewhere, that can trigger anaphylaxis, which is a systemic response. But not all foods have that. So imagine you have a patient that comes in to your clinic to your doctor's office or into your ER that consistently seems to have repeated bouts of pancreatitis. And they've had colonoscopies and endoscopies to look and see what's going on in their GI tract. And you can see visible in these colonoscopies and endoscopies inflammation in the lining in the GI tract, especially in the stomach and the small intestine. This person keeps having pain episodes that are so severe, they're passing out from the pain, and they can't figure out why they're having these episodes. But you suspect they might have an allergy to a food. They're not having anaphylactic response to that. They're having an atopic allergic response in the GI tract. So that can happen and lead to gastrointestinal symptoms. This may cause vomiting, diarrhea, abdominal pain. And if you were to look at this through endoscopy or colonoscopy, you could see the actual inflammation in these areas. Other people might eat the same allergen, but their body might trigger anaphylaxis. This particular situation where we had that atopic GI symptom stuff, which is from food, this particular patient was allergic to whey protein. If they have it in small amounts, a little bit of inflammation was manageable, but if they had a whole lot of cheese, or when, in this particular instance, when this person started having outbreaks of these pain episodes and pancreatitis and started passing out from the pain regularly, that was when it was associated with them taking whey protein shakes. And so it was high concentrations, more than what you usually get from a normal dietary exposure to whey, increasing that inflammation and leading to pancreatitis and the GI symptoms. That person was me, by the way. I'm allergic to whey protein, but I think I'm giving up cheese because I'm not doing it. It's one of the joys in life as far as I'm concerned, but I have to have it whey protein in moderation. And when I have protein shakes, I can still have protein shakes, but I have to use plant-based protein. I can't have whey. Guaranteed, every time I have a whey protein shake, or I have a shake that I didn't realize I bought it at the store and I didn't check that it was whey protein, I've always had pancreatitis as a result of it. Every time. And it is extremely painful, let me tell you. I mean, like the sweating, blacking out kind of pain, like level 10 pain. So that is what I get from my allergy to whey protein. It's wild, right? I don't get anaphylaxis, thankfully. If you get anaphylaxis and you have a systemic response to these things, you're still going to have a very quick reaction. I can drink the whey protein and within an hour, I'll be having GI pain. But these people, within an hour, if you have anaphylactic response to your allergy, within an hour, less usually, within minutes, you'll have anaphylaxis. And you'll have it. It does. So in celiac disease, you will have an allergy to the gluten protein, and you'll have the GI types of symptoms related to that. So it's lower in the colon where you'll see the inflammation, but it's a similar sort of thing. You get GI, it's an atopic allergic response. You don't have anaphylaxis with it, but you do have an allergic response to it. Okay, so drug allergies, again, this could be from contacting the drug, if you have a topical drug, or injecting the drug, or ingesting the drug like in a pill form. But these can lead to atopic, like rashes, like with eczema, or it could lead to fatal anaphylaxis. Systemic anaphylaxis, again, we have through your bloodstream, the activation of your immune response from that degranulation within your bloodstream. And this is usually going to be triggered usually by injectants, but we know you can have this from inhalants, ingestants, and contactants as well. It's just very common with injectants because you're injecting it straight into the bloodstream. So we see this with bee stings. Again, your first bee sting of your whole life would be a normal, ow, it hurts, it swells up and whatever. But your second bee sting in your life could kill you within minutes, just one bee sting. And so that's what we see with our systemic anaphylaxis. In order to block allergies, we can block basically the inflammatory response. So this could be through things like steroids that are inhibiting inflammation. But this is also why steroids over time, we don't recommend that you take steroids long term because it inhibits your immune response overall. So you might be inhibiting your allergy or inhibiting the swelling associated with your rhinitis or your pharyngitis or your sinusitis. That could be actually caused by appropriate things like having an infection or something. So I give you steroids because you've got a sinus infection. It's actually decreasing your immune response overall and makes you more susceptible to secondary infections. So we don't like to keep people on steroids for a very long period of time. We usually give them steroids for about 5 days, and we do not recommend that you continue after that, especially systemic steroids. If you're using a steroid nasal spray, that's in one location. It's keeping the inflammation down in that location. Probably not going to be this big of an issue. But if you're taking pills, steroids, or you're getting shots for steroids, it's being systemically disseminated in your body. It's decreasing your whole body's immune response. And any other drug that can inhibit your inflammatory reaction, like when we talk about Humira, adalimumab, it's a monoclonal antibody that blocks our inflammatory molecules from being able to have action. So instead of your body saying inflammation signal coming in, instead of blocking it coming into the cells and triggering inflammation, we have an antibody that binds to the receptor and says you can't trigger the cell. So it keeps that signal from getting to the cell and causing inflammation. It's also keeping it from getting to the cell and triggering the immune response. So if you take adalimumab as Humira, you're blocking your overall immune response as well as the inflammation that you have associated with your Crohn's disease or IBS or ulcerative colitis or HS, hidradenitis suppurativa. Those are all things that are used with adalimumab to treat those things. If you're at risk for infection, they tell you that if you're on Humira. Hey, if you take Humira, you're going to be more likely to have opportunistic infections like yeast infections and things like that. And you will see that in people who take Humira. So we're blocking that inflammatory thing. So it's not always good to block your inflammatory response chronically. We can also have antihistamines that just block the histamines that are involved in that reaction. So you're still letting most of the rest of your inflammatory reaction happen. But if you block the histamines and you're just doing that acutely, like if you're having allergies, like when I'm really allergic to cats, you guys, like really allergic. And so I'm borderline, I'll have a systemic response that doesn't go into full anaphylaxis unless there's multiple cats in the house and those people haven't cleaned their house in a while. I can go into that where I can't breathe and I've had to go to the hospital previously or stuff like that. But it doesn't happen immediately and it takes a lot of allergen to trigger that sort of a thing. You can have gray areas here too. But if I'm in a household where people keep their house relatively clean and their cat, they just have one cat, then, and it depends on the cat too. Some cats I'm less allergic to. That I can take Benadryl and it blocks the histamine response and I can have a normal interaction with that cat while I'm being exposed to that antigen. But if you're allergic to cats and you're staying the night at a friend's house that has a cat, is one Benadryl going to work for you? No. So you'll have to keep taking the Benadryl and blocking that histamine because it doesn't eliminate the antigen. It just stops that inflammatory response. So Benadryl is really effective at blocking histamine. We have other drugs too that block the histamine response, like Zyrtec and Claritin and Allegra. Those all work the similar way. The difference is that Benadryl can cross the blood-brain barrier. And so that effect of Benadryl crossing the blood-brain barrier is what we get with the sedation that's associated with that. So when you take like Tylenol PM, and people will just take the PM part, well, they probably don't realize, you may realize or you may not, it's just Benadryl. And so that is literally just the side effect of the Benadryl that people use to make them drowsy and help them sleep at night. It's very, very safe drug. Of course, if you take too much of it, there's a limit, right? But it's one of those drugs that you can take a pretty high dose of and it's still be relatively safe in most adult people's bodies and can help with the inflammatory response to a lot of different things, not just allergies. So, anyways, so antihistamines. If you're having a systemic response, it's something that most people are aware of. If you're having anaphylaxis, what do we treat that with? An EpiPen, epinephrine. So epinephrine, when it is delivered medically, we call that epinephrine. If your body is producing the molecule naturally, we call it adrenaline, but they're the same thing, okay? And so epinephrine or adrenaline, it basically increases your blood flow to your brain and opens up your respiratory passages so that you can keep getting oxygen in and getting that oxygen to your brain. When you have an anaphylactic response, anaphylaxis closes off your breathing because it's trying to eliminate exposure to the pathogen. It doesn't know that it's not a pathogen, it thinks it is. So it's trying to close off from the pathogen getting into your body, and it's trying to prevent that pathogen from moving from your bloodstream to your brain. So it decreases the blood flow to the brain as well. And it tries to just keep the blood circulating more in your heart, just to keep you alive momentarily, because it thinks you're going to get away. It thinks hey, you're going to eliminate yourself from this threat, right? Like you're going to do this, right? I'm going to give you a chance. I'm going to close down, but you need to eliminate yourself from the threat. And so what epinephrine does is it reverses that process. Epinephrine does not get rid of the thing triggering the process, okay? So if you are allergic to something and you're using an EpiPen, you should be moving to the hospital immediately, okay? Just FYI. If you have somebody that uses an EpiPen or you use an EpiPen, that isn't eliminating the antigen, and adrenaline or epinephrine, it only lasts for 30 minutes to an hour. And so if you're still being exposed, and especially if you don't know where that allergen came from, and you can't eliminate yourself from being exposed to it, then you would absolutely need to be heading to the hospital as soon as possible, or calling 911 when you're using your first EpiPen to come help you. Because once that epinephrine wears off, you're just going to have the same anaphylactic response, and it only takes minutes to kill somebody. Right. So desensitization, basically I can take your allergen and put signals in with the allergen to tell your body to make IgG instead. So for somebody like me that's allergic to cats, I could get injections with cat dander and things that signal my body to make IgG instead. So my body starts making IgG to cat dander. IgG doesn't trigger degranulation of the mast cells. And so IgG, because we make a whole lot more of it than IgE, IgG will bind up all of your allergen, and your IgE will never trigger your mast cells to degranulate. So you'll still have an immune response against that allergen, but you'll just never see it. Okay, so we can trigger that, but it has to be specific to the allergen that you are reacting to. And so finding that allergen, we can say cat dander, but it's probably not cat dander. It's some aspect of the cat dander. So we have to figure that out for each individual person, and then trigger their immune response to IgG, and then hope that we can trigger that in time instead of having your IgE overwhelm it. And so this isn't available for every antigen, but for some things it is. So that's type 1. Type 2 now. This is getting into type 2. This is going to be IgG and M. And this is going to be based on your blood types. You have 4 blood types, A, B, AB, and O, and they're based on genetics. If you are A, your genetic is either AA or AO. So stick with me here. All of your genes in your entire body, you get one maternal and one paternal, or father. And so if your maternal gave you an A and your father gave you an A, you're going to make type A. Or if your maternal gave you an A and your father gave you an O, you're going to get type A. If you have genes, at least one gene for A or B, you will express them. Always. So if you get a gene from mom that is A and a gene from dad that is B, that child is AB. Because they have an A gene and they have a B gene, you will express A. You will express B. So they express both. So do you have a question? Or did that
So is it like blood type kind of?
This is blood type. This is talking about that. Yes.
So when my mom was pregnant, we had to take some
We're getting to that.
Oh,
Yes. So ABO groups, these are only on red blood cells. Not any other cell in your entire body, just red blood cells. It's determined by genetics. So I want to tell you guys something. I am an A positive. My sister is AB positive. My dad donates blood. My dad is B positive. So do you know what blood type my mom has to be? A. She has to be. My dad doesn't have any A genes or he'd be expressing them. So probably, this is what I'm going to guess. My dad is probably a B and an O. Yeah, so you're probably asking, then why didn't I get the B? Because my dad probably has an O gene hiding out in there. If you have O, we're going to talk about, I have a picture of O in a second. O is the foundation for all blood types. So if you are an A, you have an O at the base and you popped an A on the top of the O. If you are a B, you are an O at the base and you popped a B on the top. If you're an AB, you are an O at the base and you popped an A and a B on the surface. But if you're an O, you're just the base. You don't express any markers for A or B. The only time you can get an O is when you have 2 genes for O. Because if you had an A, then you'd be expressing A, or if you had a B, you'd be expressing B. So the only time you can get type O is whenever you are 2 O's. We call that type of a gene recessive. A and B are dominant, O is recessive. In order to express the recessive, you have to have two versions of the recessive. Okay, so we know my dad must be a BO, and we know my mom is an A something. We'll say she's an AO, okay? Here are the possibilities of what children they could have made. So you can bring the dad genes down and the mom genes across. This is mom. This is a Punnett square, exactly. And I'm not gonna test you on a Punnett square or make you do one or anything like that, but you would learn about this in genetics or in biology. So the possible children they can have would be AB. Yeah. So AB, AO, BO, or OO. So if my mom is an AO, and I don't know, she's only got 2 kids, okay, so she could be an AA. But if she's an AO, they could have produced children of all 4 blood types, an AB, an A, a B, or an O. Those are the actual expressed blood types, right? So remember, if you have a genetic makeup of BB or a genetic makeup of BO, you're expressing B. You are a B blood type. That's the phenotype. Remember genotype and phenotype. So we're coming back to that. Okay, so that's the breakdown of genetics and how they lead to those things. And remember, O, if this is a type O, O is the foundation for all the others. So as it turns out, if I'm an A and I see B in my body, that's foreign to me. My body will attack it. If I'm a B and I see A in my body will attack it because A is foreign to me. If I'm an AB, well, I'll get to your question in a second. So if I'm an AB, I recognize A and I recognize B. None of those are foreign to me. And if I'm an O, A is foreign to me and B is foreign to me. But to all of these blood types, O looks normal. So O is the universal donor. Anybody can get O. It doesn't look foreign to anybody because it looks normal to A, it looks normal to B, it looks normal to AB, and it looks normal to O. If you're AB, A looks normal to you, B looks normal to you, AB looks normal to you, and O looks normal to you. So O's are the universal donor, but they can only get O. ABs are the universal recipient, but they can only donate to ABs. Question? No. Yes.
So what about the positive?
We're gonna get to that next. Yes. Okay, so these are your ABO. So you are either A, B, AB, or O, and you either express A antigen, B antigen, both, or none. And this is what's going to determine our susceptibilities there. There's a chart that breaks this down. As it turns out, the most common blood type in the United States is the recessive O. Now, why would that be? Short version of the story. If you have type O blood, you are less susceptible to malaria, proven by science. So that gene has carried throughout time because people with O survived better. So we actually see a higher incidence of O probably due to that. We can't prove that, right? But that's the hypothesis on why that is. As it turns out, also, mosquitoes have evolved for that. Mosquitoes prefer type O blood. This is a fact as well. I have type A blood and my husband is type O positive, which is the most common blood type. I'm A positive and he's O positive. And I can assure you that the mosquitoes prefer his blood over mine. If I go outside, I will get far less mosquito bites than he will, even if we're out there for the same amount of time, because he's O and he smells better than mosquitoes. So because O is more resistant to malaria, mosquitoes have adapted to try to infect more of those people because they have to infect them more. Basically, there's a genetic predisposition to that. There's a long story that goes involved in that, but that's kind of the hypothesis on why that's worked out the way that it has.
So like example of Darwinism and how the strongest traits survive.
Yeah, that's an example of that, basically natural selection. Okay, so we see that very obviously in like microbes because we can see it happen like within days, but in humans, we have to look at it over a longer span of time, right? Because we don't multiply as fast. So this leads to type O being the universal donor. Anybody can get it. But if you're type O, you can only get O. So there's a problem there. If you have a mass, trauma response for a whole lot of people, like there's a big bus wreck or something, and you don't have time to figure out other people's blood types, then you're going to get people O negative. O negative is the universal donor, really universal donor. And so anybody can get O negative. But what happens if an O negative person comes in later and you've used up all the O negative on all these people who, sorry if you're O negative. Thank you for your donations though. Okay, so if I give you the wrong blood type, this activates the complement pathway and those MACs that are going to poke holes in the target cells associated with complement activation. So this activates the classical complement pathway because my IgG will activate complement through the classical pathway and cause holes to poke in those wrong blood type. Okay, so I'm A. If you put B in me, my complement system will get activated and target those B cells. Then you have leaking of all these red blood cells from being destroyed. And that signals your body, hey, what the heck? We've got blood cells dying somewhere. That causes a shock response and can kill you very quickly. So if you infuse somebody with the wrong blood type, you have a very short time to start in with cleaning out their blood basically through dialysis. And so helping eliminate the toxins that are made from those ruptured blood cells can also lead to, if you survive from something like this, death is very common for this situation. So if you were to survive this, you will have anemia because you've not only destroyed the bad guy ones, the wrong blood type, but it can also lead to destruction of your own red blood cells, just getting lost in the big massive response. And the shock response, low blood pressure, in addition to losing your red blood cells, can lead to hypoxia very, very, very quickly. If you survive it, you will have jaundice because of liver damage associated with dealing with the toxins released. You will have splenomegaly from your spleen trying to eliminate all those ruptured red blood cells. And you will have to have dialysis to help remove all those toxins to prevent the damage that's being done as a result of that, the activated complement, basically, as well. So next, we have not just ABO, but we have RH factor. RH is whether you're positive or negative. So you either have RH or you don't. So RH negative is like the foundation one, kind of like O was. So what RH negative, anybody can get RH negative. But if you're Rh positive, you have this extra antigen on your cell, this Rh rhesus factor, what it is. That Rh factor, you either have it or you don't. If you're positive blood type, like A positive like I am, then you have the rhesus factor. I'm A positive, so if I get A negative blood, it just looks like A without the rhesus factor. That doesn't look weird to me. That looks normal to me. But if you are A negative and I give you A positive blood, you will see that rhesus factor is something foreign that you were never basically trained to see as normal, and you'll attack it as foreign. So it'll lead to the same effect. This is what governs hemolytic disease of the newborn and why we give RhoGAM. If you are Rh negative as a mother, you're carrying an Rh positive baby. In your first baby, you're just sensitizing against that antigen, okay? And so that whole process is basically creating antibody to the Rh factor in your baby. But your second baby, you will have already been sensitized and you can make antibody immediately. Just like the first bee sting, you don't have a reaction to, the second one you have antibody to. The first baby, you're making the antibody so that when you have your second Rh positive baby, it can attack it. And this will lead to stillbirth in most cases. So if you're an Rh negative mother, they don't care if you've had a previous pregnancy. They're not going to mess around. They're going to give you RhoGAM. Because you may have had a miscarriage that sensitized you that you didn't know about. Or you might not be aware of your medical history and not sharing all of it with the doctors. They're just going to give you RhoGAM if you're Rh negative and you're pregnant, and you could potentially have an Rh positive baby. So if they know the blood type of the father, if the father is positive, then there's a risk for an Rh positive baby. They don't need to do the blood typing on the baby to determine that. They're just going to give you RhoGAM in case. All right, it's that serious. If you think this doesn't happen nowadays, you're fooling yourself. Imagine changing your doctor and you didn't keep up with your blood types, or you never knew your blood type of your spouse and you just never knew about this being an issue. And so they're going to test the mother for Rh negative, hopefully. If you're Rh negative and you don't know the father, we're going to give you the RhoGAM, or you don't know the father's blood type. The father's blood type is available and they can get tested. Then we can know whether or not to give RhoGAM. RhoGAM is expensive. So it's not something you want to give if you don't need to, but if there's any chance that you might need it, we're going to give it. Because if you do not give it, stillbirth is the most common outcome. Imagine carrying your baby to 9 months, and then when it is born, it's dead. Because that baby will be alive until birth. Because at birth, we have the disruption of the placental barrier. That's when the antibodies come in and attack the baby. So the baby can be born, and it might be stillborn, or it might die very shortly after birth. There's usually nothing they can do for that baby once that reaction starts. Imagine that. So that's why this is so important. Did you have a question?
There's no like bad effects of it if, like, say they ended up not needing it, but it was good.
Right. Yes. No bad effects. There might be some side effects, but like when you're talking about the death of a baby, then this is the alternative. You can, so you might be thinking, if I'm an A positive mama and I have a B baby that I'm carrying, can't that same attack happen? Yes, but for whatever reason, it's not as severe. So you guys hear about these babies that are bilirubin babies that have to be put under the Billy lights? Probably the second baby that was the wrong blood type compared to the mom, not RH, but ABO. So if you're an O mama and you're giving birth to your second baby that was A, then that mama may have antibodies against the A. It attacked the baby. That leads to jaundice of the baby from the effects of the attack from the mama. You know, put them under a Billy light, and that just helps the body break down the toxins that were made from that. That's way more survivable. Most common reason why we have Billy babies.
Oh, my daughter had, like, she was
Yellow.
like jaundice.
Was she your second baby or your first?
She was my first.
So she was your first. So there might have been some other incident where you were sensitized to something, but it also could have been due to other factors. It might not have been.
I think she is actually a different blood type.
Yeah. And it depends on the blood type, and it depends on if you could have been sensitized previously for other reasons, or, you know, we sometimes don't know if we maybe had a baby pregnancy that we just never knew that we had, or something like that could have sensitized us. We're not always aware of these things that happen. And so these things can sensitize you, but there's other things that can cause Billy babies as well. So just to be clear.
My mom was pregnant with me also. I think my dad is RH positive,
Mhm.
he's RH negative.
Mhm.
So my mom had to have that thought because she was telling me I need to take
Yeah. Yeah, but if you were positive, then you're good. You wouldn't need RhoGAM. So, well, you know, not everybody understands why that is or how it works. So, but anyway, so moving on to type 3. Type 3 is basically associated with this situation. We have antibody binding up and creating complex with antigen. So the blue is the antigen, and the wire-shaped purple guys are the antibody. These things get trapped in our basement membranes, or basically like the surface cells of like your capillaries and things like that. And then we have inflammatory response and complement reactivated by these guys that are getting stuck there. The body's still reacting, it thinks that it needs to react to a bad guy that's there, but they're just they're just complexes of the antigen and antibody getting stuck. This can cause inflammation in joints and in blood vessels. It's why you get the butterfly rash with people who have lupus. The capillaries in the face that are very, very fine capillaries are being destroyed because we're reacting to these complexes that got stuck in those capillaries. It's why you get rheumatoid arthritis. We're reacting to complexes that got built up in the joints. And then the inflammatory response against those complexes cause damage to the tissues there. There's another one called acute post-streptococcal glomerulonephritis. This is essentially acute. If you have had strep throat, some people, the antigen left over from fighting the strep throat, so the actual strep antigen that has complexed with antibody, gets stuck in your kidneys while it's trying to filter everything out. And then the immune response comes and causes inflammation in your kidneys. This is associated, it's a short-term thing until your body clears it out, but can be deadly. And not everybody gets this, but some people do. And this is called acute because it's only associated with recovering from strep. Post-streptococcal, because you're recovering from the strep, the antigens of strep and the antibodies against strep getting stuck in your kidneys while they're filtering. And this part of the kidney that does the filtering, I'll get to you just a sec. The part of the kidney that does the filtering is called the glomerulus. Yes, and that it's part of your kidney, nephritis. So it's itis, inflammation of the kidney, nephro, glomerulo, the part of the kidney that's being. Okay, did you have a question?
So is this for anybody that gets stuff, or is it people who were so get like a year?
people who have created, so some people, based on how your genes reassorted to attack certain antigens, remember how we have everybody's genes are going to reassort differently. It's very unique for every person. So how that person's genes reassorted to make this antibody against this strep antigen has caused them to be more likely to have these complexes that will get stuck in the kidney. So only some people have this, not everybody that has strep, but some people that have strep, if their antibodies create these complexes that get stuck in the kidney, they could have an inflammatory response in the kidney leading to glomerulonephritis. You're welcome. I don't make you write that word.
Is that the same as like, Strep does a lot of things like that.
I was gonna say my cousin,
You have, like panic cause, like scarlet fever or
Yeah.
something like
Yep.
that.
So scarlet fever, what that is you'll get a rash on the body, and little kids get this all the time. So scarlet fever, what happens with that is some people make antibodies against strep that also attack self molecules. So strep has molecules on its surface that look like self for some people. And so when they make antibodies against the strep, those antibodies also attack self. And when that happens, you'll get a rash, usually all over the body. That is scarlet fever. So if you ever had a kid that had strep throat and ended up getting a rash on their body, that is scarlet fever. Every time. Like, it's not an exception. That's scarlet fever. It's treated the same way though. So it's whatever. But like, we will get rid of that infection, and then those antibodies that need to attack self, they don't stick around. It's usually associated with that infection being present to trigger it. Yes. Uh-huh. Right. So smoking can basically increase the inflammatory response, or it can also inhibit the immune response. So people who are smokers tend to be more susceptible to infections because their immune response is being inhibited. And that can cause you to have your inhibited immune response. And then you'd be more likely to get infections from opportunistic pathogens. As it turns out, things that cause ear infections and upper respiratory infections are opportunistic pathogens. And so there's a reason why some folks are more likely to get ear infections versus other folks. And that's because maybe some people's immune systems just aren't as geared towards fighting off those opportunistic pathogens. They just didn't reassort to be able to fight them off as well. And so being around smoke can actually decrease. You might have the ability to fight off ear infections, but being around smoke can actually make you more likely, like, I'll say this, it weakens your body's ability to fight it off. So yeah, that actually can be associated with that sort of response. So moving on to type 4. Type 4 sensitivities involve T cells. This is essentially your T cells thinking that your cells are infected with something. So doing that inside response, killing with perforins and granzymes because we think that the cell is infected with something. This usually is associated with a couple of things. 3 obvious ones that you need to be aware of for the exam. Tuberculin skin tests. If I inject a little bit of tuberculin antigen under your skin, so obviously the antigen associated with tuberculosis, right? I will inject a little bit of it under your skin. In 2 to 3 days, if that has swollen up and it had an inflammatory reaction, it means that your CD8 T cells had memory of that antigen. So your CD8 T cells cause a delayed memory response. Antibody can be made immediately by your memory B cells. But your memory cytotoxic T cells, you only have a few of them. But when they get activated, they have to multiply because the cells are doing the work. And so it takes 2 to 3 days. It's still less than the week or 2 that it took to make them in the first place. But 2 to 3 days to go from the few memory up into enough to have a response. So this is a delayed type hypersensitivity because we have to let those T cells repopulate. So 2 to 3 days later, we will come and check that injection site. If it has swollen up, then to a certain size, that indicates that you had T cell memory to that antigen. The only reason you will have T cell memory to tuberculosis is if you have tuberculosis, have had tuberculosis, or you had the vaccine to tuberculosis. We do not give the vaccine to tuberculosis in the United States traditionally, unless you're traveling out of the country to areas where this is a problem. It's a travel vaccine here in the US. So if you test positive with your tuberculin skin test in the United States, you have probably either you have tuberculosis. If you didn't ever know that you had tuberculosis, then you probably have it. Or if you've had tuberculosis, the only way you're going to clear it out is through these very intensive medication cycles that last 6 months or so. You would know it, man. You don't clear it out naturally, ever. So,
Tuberculosis, that's also called,
yeah, TB.
because I know that Norman just had somebody who went to school.
Yeah. It is highly contagious, yes. And so this is one of those things you can carry it very easily without any symptoms. So that's why they test you before you work at a medical facility, because you could just be carrying it around. If yours swells up and you're like, I haven't ever had tuberculosis. Sure about that? Because most people carry it without symptoms. And so be aware of that. It's actually more common than you think it is. So what they'll do next is a chest x-ray. And if your chest x-ray has any like cloudy areas in it, that suggests that you have tuberculosis. But we're gonna push through this.
Treatable,
It is treatable with 6 months worth of antibiotics.
but then you don't have it.
And then you don't have it anymore, yes, as long as you adhere to the treatment, yes. So this also relates to contact dermatitis, like poison ivy. Your body thinks it's infected inside with something, and so we're killing your cells, and that's why you get that weepy, really inflamed, flaky, horrible rash. This is from your T cell response killing things. It's also why, if you're allergic to jewelry, if I wear crappy earrings, 2 days later, I will get that itchy, weepy grossness around my ears. That's why. It takes a couple days. Same with poison ivy. It's also the mechanism by which we attack grafts that don't match us, because the inside response is driven by MHC1 presenting inside stuff. And all cells can have MHC1. If I get your kidney, your MHC1 just looks foreign to me, but it also still looks like MHC1. So my body interprets that as MHC1 is saying there is inside antigen right now, and I'm going to kill all the cells that have that going on. And so it just kills all of the kidney cells if we don't match up those MHCs exactly. And that's what the HLA labs do. And remember, HLA is the same thing as MHC. And so if my body attacks the kidney that I'm given, that's called host versus graft. That's the host attacking the graft. If I get a transplant of bone marrow, remember, bone marrow has the cells that do the attacking. So if I have leukemia and I get bone marrow, and that the MHCs on the bone marrow doesn't match my cells and whatever, then those bone marrow cells will attack my cells. And so that is graft attacking the host, graft versus host. And it only happens with bone marrow transplants. But if you're attacking the organ, and the body's attacking the organ, that's the host attacking the graft. There's different kinds of grafts that you can get: auto, iso, allo, and xeno. Auto is from yourself, so skin from your back to heal a burn on your arm. Iso graft from somebody who's genetically identical. These are only identical twins. Allografts from somebody who is not genetically related to you, but is still a person. So my sister is not genetically identical to me. She's my little sister. So we can't be genetically identical. So if I got a kidney from my little sister, that is an allograft. And then we have xenografts. Xenografts are from other animals. So you can get heart valves from pigs, for example. Okay. Autoimmune diseases are when our antibodies or our T cells are attacking self-antigens. It should have been eliminated during our maturation process, but they weren't, and they got activated instead, and now we will chronically attack self. This can be systemic or it can be organ related. Lupus, rheumatoid arthritis, Graves' disease, myasthenia gravis, type 1 diabetes, and multiple sclerosis are all autoimmune diseases. Type 1 diabetes is when our T cells attack our pancreas cells that produce insulin. So the T cells think our pancreas cells that produce insulin are infected inside and kill all the insulin producing pancreas cells. They can't even make insulin. And that's why, is because it's an autoimmune thing. That's not the case with type 2, which is metabolic. This could be due to the molecules mimicking molecules that look like self, or it could just be because you're infected with something, triggering the self molecules got caught up in that activation stuff and didn't get regulated properly. And that is what we think leads to MS and type 1 diabetes, is that there was an infection going on in the body that accidentally triggered reaction to these other cells. Now, we still got to go over chapter 18. I got to at least run through it. All right. I'm not coming back to it. So this is the only time I'm going to touch to it. All right. So that's that. Primary immunodeficiencies, genetic from birth. You had a genetic defect that caused you to have either deficiency in making antibody, B cell deficiency, or deficiency in your T cells. We've already talked about if you have deficiencies in your T cells, that causes deficiencies with B cells because you can't captain them. So having a T cell deficiency is worse than having a B cell. But there are diseases like SCID, which is X-linked, SCID is X-linked severe combined immunodeficiency, where we have a deficiency completely in your entire B cell and T cell response. Those people can have no memory generation of any disease ever for their entire life. That's the boy in the bubble disease. It's the boy in the bubble because it's X-linked. How many X's do women get? 2. How many X's do men get? 1. They don't have another copy of the gene to compensate. So they only get 1 copy of the gene. And if that gene is messed up, they have no other gene to compensate for that. So it is X-linked. The only time that women can get X-linked SCID is if they got 2 versions of the gene. And so one of those versions would have to come from a man that had SCID. So you would have had to reproduce with a man that was a boy in the bubble. The only time that would happen is never. They've never lived that long. They die in childhood. There's no man in a bubble. They die because they get sickness. We can only control it to a certain extent. How do you keep something like that alive and feed them? They can't respond to that, right? So that's genetic. For the secondary, those are acquired. It's acquired after birth from HIV infection, which is the most common one leading to AIDS. Or you could have cancers that affect your immune system, like leukemia or lymphoma. It's affecting your ability to make B or T cells and how those B or T cells can respond. It's severely impacted by having those cancers. Or you could have gotten radiation therapy to treat another cancer. And the radiation kills off your immune cells, and now you're more susceptible to other infections. Those are all ways that you can acquire. It can be temporary, or it could potentially be permanent, like we see with HIV. I mean, drugs can treat that, but if you don't keep on the drugs, it's forever, right? Okay, so that's that. What else is there in here? I'm not missing anything else, am I? So really quick, I want to summarize chapter 18. We've learned about a lot of the tests that are covered in chapter 18. But the big things that I want to cover really quickly, there are 3 major categories of diagnostic tests. There's a 4th one that we'll call other. This is like imaging techniques, like CT and X-ray and things like that. Immunologic tests. I'm going to start with the immunologic and genotypic because these are very straightforward. Immunologic tests are basically based on recognizing, this is definitely me spelling things incorrectly, recognizing antigen. That's your immune system that does that. That's why it's immunologic. So this is based on usually antibody being present or antigen, and we're using antibody to identify it. If it involves antibody antigen, that's immunologic. Or if we're doing the PPD skin test, that's checking to see if you have a T cell response. That's an immunologic test. Okay? It depends on seeing if you have an immune reaction or using immune system stuff to see if you have antigen. That's immunologic. We'll put antibody on here as well, just to remind you guys it could be antigen or antibody, but it's sometimes T cell related. Genotypic. This is literally based on nucleic acid sequence. DNA sequence, RNA sequence, either PCR, which we learned about previously, we can use to see if you amplify a sequence out from PCR, you have the gene. We also had hybridization. We can make a gene sequence and see if that gene sequence matches your patient's sample. We can do that in actual tissue. We mentioned something called FISH previously, fluorescent in situ hybridization. That is using a DNA sequence that we know matches, this, let's say this cancer, this mutation for this cancer. And I'll take that and fluorescently label it. Then I will take your patient's biopsy sample and I will mix the biopsy sample and put that mutation with the fluorescence on it. And if I look at your patient's biopsy and it glows fluorescent, that means that the DNA matched the DNA in your patient sample and caused it to glow. Your patient has that mutation. So that's FISH. It's in situ because we're taking the actual biopsy. We can test the biopsy sample itself. So keep that in mind. In vivo means we did it in like a test tube. And if we're, that's, what did I just say? In vivo means living. So that's living tissue. So the PPD test is actual living tissue. So that's PPD test is in vivo. In vitro is in the test tube. In situ is like using a tissue sample. It's like kind of in between. Okay, so those are the differences. And you probably heard the term in utero. It is what it sounds like. Situations that are in the uterus. So genotypic tests deal with the DNA or RNA sequence. Immunologic tests, we are recognizing antigen or antibody or a T cell response, but that's still recognizing antigen, to be clear. And phenotypic, these are usually based on metabolic or biochemical or physiological. This can also include things like phage typing. So phage typing, every single phage, bacteriophage, viruses that infect bacteria. Every virus that infects a bacteria, that phage can only infect one bacteria species. So if I think you have salmonella and I have a bacteriophage that infects salmonella and I mix the samples together and I see that your bacteria got killed by the virus, you have salmonella. If I mix that salmonella phages that only infect salmonella with the patient sample and it still grows, that is not salmonella. It's something else, maybe E. coli. Okay, so that is a phenotypic test. Metabolic test, whether it grew on selective or differential media, whether it was able to ferment lactose or ferment glucose or ferment mannitol. Mannitol salts agar is a phenotypic test. So these are all tests that we've learned about previously, but now we're categorizing them as phenotypic, immunologic, or genotypic. We might need to culture the guy before, or we might be able to test that thing directly. You could also look at things like colony morphology. It's a phenotypic test. All right. An immunologic test that I need you to know of, we talked about most of these phenotypic guys, and we'll learn about dichotomous keys. We'll actually use a dichotomous key. Basically, a dichotomous key relies on, you'll take a factor like, okay, when you looked at your sample in the microscope, was it a coccus or a bacillus? It's a coccus. Was it gram positive or was it gram negative? If it's gram positive, did it have a catalase reaction? Did it bubble up when I added? We'll learn about what this is later. You have to know it now. Did it have a positive reaction for catalase or a negative reaction? Did it have a positive reaction? Was it an aerobe or was it an anaerobe? And if it was an anaerobe, it's probably staphylococcus or whatever that is, planococcus. That's a dichotomous key. And you have to go in order. You can't just say, well, I have a sample and I know for sure that it was a facultative anaerobe. You can't just jump to this because what if it was gram negative? And this doesn't apply. It's not this. You have to go in order on the dichotomous key. This is the biggest mistake people make at the end of the unknown lab report. They just say, oh, mine had endospores. They didn't consider whether or not it had this thing first or that thing first, for example. Okay. Have to go in order. All right. So we'll use all of the results from the biochemical tests, all the tests that we're doing in our lab, whether it ferments lactose, sucrose, glucose, or glycerol, or mannitol, or whether it makes a sulfur byproduct, or whether it can grow aerobically or anaerobically. We can pop all that onto this card here and do them all at once. These cards cost about $500 to $1,000 a pop. That's why we don't do it in lab. Y'all want to pay for that out of pocket? So we have to do the test individually, but those individual tests can be summarized in one of these cards. All right, we talked about all this other stuff. Really quick, for our immunologic test, one of the tests that I need you to be aware of, we already know about direct and indirect. Direct and indirect immunological tests don't just apply to ELISA. It applies to all immunological tests. The immunological test is either checking for the antigen or checking for the antibody. Remember, if you're checking for the antigen, that is direct. If you're checking for the antibody, that is indirect. Okay. Agglutination checks for whole viruses or whole bacteria, seeing if they stick together from antibody. Precipitation, antigen, not just the whole thing, but just the antigen is complexing with antibody. Immunochromatography, we have a color change that is going across usually a paper. Your home COVID tests are immunochromatography. Your pregnancy tests, immunochromatography. Western blot, this is the new one that you need to be aware of. Western blot, we have electrophoresis. You remember how we did the DNA electrophoresis? You can separate proteins, it works the exact same way. So proteins will separate by size, we'll spread them out on a gel to separate them, then we'll mix them with antibody to see if the antigen is there. That's Western blot. Okay, fluorescent antibodies, usually like linking the antibody to a fluorescent molecule or linking it to an enzyme, and then the enzyme cleaving something to call color change. That's ELISA. We learned about that. Then in vivo tests like the PPD tuberculin test. Then the genetic tests, we've really already covered the genetic tests, honestly. That's PCR. God, look at all the summary of this stuff. PCR is our genetic tests. We also have hybridization, which is matching whole sequence to other sequence, and then genome sequencing of the whole genome. We can do this on a large scale, on a big old plate. We can put a whole bunch of genetic markers on it and then mix the patient sample onto the genetic markers and see which ones it bound to. And that can tell us if you have a whole slew of different mutations that are associated with different kinds of cancers. It's just a big way of doing it all throughput. We can link a whole bunch of these tests on one microchip and then plug it into a machine, and the machine can analyze it. This, of course, is really expensive right now. But the idea that this will get automated and very affordable, and it would allow people to test in third world countries where they don't have actual laboratories that can do the individual tests. MALDI-TOF is another test. This is mass spectrometry. It shoots things with a laser, ions fly off, and based on how long it takes the ions to get to the sensor, we can break down the exact molecular makeup of a molecule. This is really useful for determining drugs, but we can also use it for identifying certain microbes as well. So this is called time of flight mass spectrometry. There's a video for that if you want to see it. Then we have imaging. You guys know how that stuff works. That's it for chapter 18. Thank you for hanging out with me to summarize that stuff. If you want more detail, be sure you understand at least as much detail as what is in the study sheet. We're gonna head up to the lab and knock that out today. It shouldn't be the worst, but it's not gonna be the shortest lab, but it shouldn't take the whole day. It's hot in here now.